Hello, everyone. My name is Gigi, and I am IPP's Community Navigator. Thank you all for joining us today. Our Lunch and Learn for the month of September is called Behind the Walls, Health, Sickness, and Survival in IDOC. And at its heart, it's about humanity. Every human deserves access to health care when we're sick, but inside the prisons in IDOC, health care is often delayed, denied, or diminished. Prisons do not have the facilities to properly treat and accommodate people who are sick and dying. This often results in tragic stories that really make you question the values we claim to uphold in society. As you all may know, I served almost a decade in IDOC myself. And even though I've never really been sick with anything worse than the flu, I can tell you it wasn't anything nice. For starters, imagine only being allowed one roll of toilet paper for the week. And that's the same roll I had to use to wipe my nose through the flu and use to go to the bathroom. It sounds impossible, right? That's because it was. I had a roommate by the name of Miss Deb, may God rest her soul. And she was diagnosed with stage 3 lung cancer at 20 plus years into her sentence. I worked as a seamstress with Miss Deb, and she would stay in healthcare for something. And it wasn't until she began coughing up blood that learned that she took it seriously. And by that time, they were telling her she had like 2 weeks to live. Now Miss Deb did make it home to her family before she passed away by an emergency medical clemency. But it also took months for her to get it granted. And it was having to watch her lay in a cell and slowly die, with no type of comfort or humanity that really took a toll on all of us. The most comfort provided for her was an air mattress because her body was in so much pain to sleep on the crappy mattresses that we did, as if they were even comfy. Oh, and they also allowed her to shop as much as she wanted to. So basically give them all her money before she passed, right? I watched Miss Deb buy hundreds of dollars of commissary with no appetite to eat anything. We watched her suffer, and there was nothing we could do about it. And I mean, I guess we could try to make her comfortable. I wound up slipping into depression while Miss Deb was my roommate because it was just a lot to watch, and I truly grew to care for her. The whole room did, actually. I share this story with you today because it is important to understand that the real human side of this conversation. Think about what you feel like when you are sick. What are those little items of comfort that you use to make you feel better? What do your loved ones do to care for you? Today, even as we get into some more technical talk about petitions and hearings, I don't want us to forget the human rights and dignities involved here. Now I will let our panelists share their experiences with you. First, I would like to introduce Ronnie. I'll let Ronnie introduce himself.
My name is Ronnie Carrasquillo, and I spent 47 years in the Department of Corrections. And from 2010 forward, I basically had medical problems, or major medical problems, and that started my introduction of what the medical system was. So that's who I am.
Thank you, Ronnie. Um, Next, I'll let Nadia introduce herself.
Thanks, Gigi. Yeah, my name is Nadia, and I am one of the staff attorneys at the Illinois Prison Project. And I handle a lot of the petitions that we file for medical compassionate release under the Joe Coleman Act. So that is the kind of framing that I come to this space with, and I'm happy to be here today.
Thank you so much. So, Ronnie, can you share what it's like to get sick while incarcerated? What does it take to get treatment? What types of accommodations or support do you get when you're sick? And in what ways were your family able to support you or care for you in this time?
So to share what it's like to get sick while you're incarcerated, first you could say like fear. There's a fear involved that number one, the institution has a reputation of whatever you go to the hospital for. Everybody says, "Oh, you're just gonna get Tylenol, and they're gonna let you go back." So you're not gonna get inspected or what's really gonna happen. So that fear of that, the second fear, you have to go sit there long hours. They purposely do that for, in case people are just, want attention and just be there. So they make you sit sometimes 5 to 7 hours and even longer, just to be seen by somebody. So nobody wants to go through that. And you don't know if you have a problem or not a problem. Something's wrong with your body, but you don't know. So those are your first, man, I gotta go play this game, you call it. I gotta go play this medical game. Then, as far as, what you can call it, family support and all that, you can explain to your family. And I'll get into, I don't want to talk everything right now, but I'll get into, like, they did finally take me out and I was in an outside setting for days. And while you're in that setting, your family's been fighting for you for the longest. Now all of a sudden you're in a setting where you can't talk to them and they can't talk to you. So you're being medically done, and especially major things like heart operations or whatever. And you're just in a custody where you can't call out, they can't call in, and it's for days at a time. So that fear just compounds, and people know, oh, you're going for the heart operation. Why do we engage? You just don't. I'll be back when I be back, and if you don't make it back, you just don't make it back, and that's a trauma in itself.
Yeah, that's true. That's so true. I know even when I had the flu, I'm a big baby when I'm sick. I want to be spoiled. I want to just love on me. You don't get that in prison. Um, I don't even recall like even getting medicine for, it was just like, oh, you got the flu, you just gotta let it run its course. So there's no like medicine to take to soothe the sore throats, nothing. Um, and it's definitely like even child, like, I couldn't eat, they say like take liquids or whatever, like there's none of that in there. So it's either you go to child or you just don't eat while you sick, and which is not good. So I can definitely attest to that. No family. If you are too sick to even get on the phone, your family won't even know you sick. So yeah, I definitely agree with you, Ronnie. So for both of you, what are the biggest obstacles you have seen in trying to receive medical care while at IDOC? Ronnie, from your experience, Nadia, from your clients. And why is it so hard to care for people who are sick in these spaces?
In my personal experience, in my personal case, I couldn't breathe one day and didn't know what it was. And actually, I was stroking, you call stroking, or miniature strokes. And then because the nurses would come, and the problem with that is they like kind of like diagnose you, like they think that they know what's going on or not going on. And they actually make judgments right like there that I think this guy's faking. I think he's not telling the truth or whatever. So the condition that I was diagnosed with later on is called ischemia, which is a hidden coronary artery disease. So my heart was polluted, plugged up, and the nurses through an EKG and all that, you can't detect this. You have to be injected with a nuclear radiated shot to light your heart up to determine. So when I was steady complaining, I can't breathe, and be knocked out and get knocked out, fall out. They're like, he's faking. So they would judge you like that instead of, and that's one of the bad practices of that they judge you and not take you to the person that is like a cardiologist, who can determine and understand what that is. And that's how my treatment started. They diagnosed it in like January, and they didn't work on me until June. And the treatment was saying that you're passing out because your brain is not receiving enough oxygen through blood. So it took them 6 months to do that. And if it wasn't for an old man, a doctor, when I was telling him I keep my body locking up, he determined that's ischemia. So he was the first person to use that word, and I had to find what is that word? I never heard it. And that's one of the bad things that I would say about that system. I won't go deep into the other one is that when I finally had some heart treatment, the cardiologist would say, I need you back here in 6 months. Or I need you back here the latest in 1 year. And when I would say to them, hey, my 6 months is up, I need to check, am I okay or am I not okay? They don't do follow-ups. So you don't get to go check back unless you fall down on the ground. And then when I did say, hey, I'm having chest pains again, They locked me up in a butt naked room and held me for 30 days just to see, is he faking or not faking? So now you're not supposed to be stressed out, but I'm sitting in this room with no personal property, no clothes. You have to ask for water. You have to ask, can I come out? Uh, and here you're traumatized and you're not supposed to have stress on your heart. And that's what they do. So my conclusion came in the end, when they were saying, you have to let us know if you're having problems. I'm not telling you nothing. You're not putting me in a butt naked room again. I'm not doing that. You'll find me on the floor. So that's the experience that I had with that. And there's a lot more to it, but that's enough right there.
Yeah, I don't have personal experience being inside of IDOC. Everything that I have heard from clients and just, from folks that are incarcerated definitely echoes everything that Ronnie just said and everything that you've said, Gigi. I think there are just so many points at which there are systemic failures, right? And systemic hurdles for people. Exactly like you said, Ronnie, I think a huge, huge issue in the beginning stages is just having someone believe you, having people take your complaint seriously. I think that I have heard countless times from folks that, they are telling nurses, they are flagging down COs, letting them know what they're experiencing, and people are told that they're faking it, or people are told that, it's not that serious if something, and then years down the line, you see in people's medical records, they did try to raise this issue, they did try to get help, and now it's too late, now that they're finally getting care. Um, and then, exactly like you said, Ronnie, even when people are heard and listened to, the folks inside IDOC are not experts in, every different type of disease, every different type of care that's needed. Some of the medical directors are allergists at these prisons. They don't know, they cannot, diagnose cancer. They cannot diagnose these things. So even when they are listening, there are misdiagnoses, or, they are not performing the right exams. They are, not checking for the right symptoms. And then, I think that at the point where people are getting, brought to external hospitals to get treatment, there's then that additional layer of the bias that, medical professionals have against incarcerated people that are looking for treatment at hospitals. So there's just so many different layers and levels. And I have definitely seen what both of you are saying, where, people are needing to go back for treatment at a different timeline, or, sometimes it's the case that someone is told they need a certain type of treatment, but because they're incarcerated, they can't access it, right? Because IDOC cannot provide them the support and the care that they need in between, chemo sessions or something like that. So, yeah, I definitely have seen a myriad of so many different issues. And I think that um, especially for folks who are not able to be admitted into the infirmaries at IDOC, there's just so many different layers. And I'm sure there's so many additional points where there's issues and hurdles that I'm not even, aware of.
Yeah, I would definitely have to agree with you on that one. I've dealt with my own small obstacles to get receive care in IDLC myself. So for both of you, for people with ongoing or chronic health problems, how are those managed on the inside, if at all? And anybody can answer this.
I can go first for this one. I think my understanding is that it definitely varies, by institution. But I think generally, most prisons have a healthcare unit, and I think most, if not all, have some sort of infirmary. And those are places where if folks have chronic health issues, and if they are, the most severely sick out of all of the people there, they might have the ability to be admitted into that infirmary where they can have access to nurses throughout the day. But that's absolutely not the case for everybody, right? The people with ongoing or chronic health issues, I think what I most often hear from people is, a lot of people are not deemed severe enough or sick enough to be admitted to the infirmary or the healthcare unit at the prison. And so they're having to flag down COs or rely on roommates or cellmates to be able to get them the care that they need. And then obviously the care that they are receiving in response to those elevations is insufficient. So I think that it's managed poorly, to say the least. And I think that I think the point that you made, Gigi, of like how, on the outside, it's just, okay, I'm gonna DoorDash some ZQuil, or, DoorDash some Mucinex or something like that, even if you don't have people you can rely on in the moment. And that's just not the case for people on the inside. But definitely want to hear your perspective too, Ronnie.
In my case, what happened to me was they put you on what's called a clinic. So you have hypertensive clinic, um, cholesterol clinic, heart clinic, cardio clinic. You have all them clinics. I was on them clinics. What that means is that they call you in more often to check on you. So, and then in a sense, it's an experiment because they give you this drug to take this and take that. So one of the problems with that is with the system is, of course, they're giving you the drug to say it's to help you. And even my natural instinct was to have my family go to doctors and go to clinics and research, hey, what is this side effect and what's this thing going to do to me? So by doing that, I found out certain things that was not right for me. And when I would bring it to their attention in the clinics, they would say, you're not a doctor. We're a doctor, and just trust me to do this. And they started giving me a blood pressure pill that even reduces your heart rate lower until my arms and my legs were freezing every day, and it's 90 degrees outside. So when it came to their attention, if it wasn't for a young, smart girl, this guy is steady doing this, and on a misdiagnosis. And when that young lady realized, hey, your heart's low, what are you taking blood pressure for? So if it wasn't for my sister and my family giving me that paperwork to study side effects, that conversation would have never happened. And I would have been steady freezing and freezing, just putting on sweat clothes.
Whew,
So
I'm sorry.
yeah, it shakes you up.
Yeah, that's wow. I'm not surprised, I hate to say. But that's scary. In your own opinions, what do you think are the biggest systemic failures in IDOC's healthcare system? How different is the healthcare for people in IDOC compared to what people on the outside might expect it to be?
I think there are so many systemic failures with IDOC's healthcare system, and I know we do not have time to talk about all of them, but I will name, I think one of the biggest ones that comes to mind for me is, like the timing of healthcare. I think, like we said, it's already such a hurdle to have someone really hear you and believe you in the first place about what you're experiencing. And then even when they do believe you, the time that it takes for you to get to see a specialist or for you to get to see an outside, external doctor is months, right? And I think something that's especially prevalent in my experience with these Joe Coleman cases that I'll talk about in a little bit, is the prevalence of prostate cancer, especially in Black men in IDOC, and how it not being caught early enough turns it into a terminal diagnosis when it never had to be that. And just I know plenty of uncles and elders that got diagnosed with prostate cancer on the outside, and they were able to see a specialist really quickly, and their prognosis is worlds different from clients that I've had who have been in IDOC, who have been asking for exams for years, have been denied those exams, even though there are administrative directives saying that they're supposed to get those exams, and then that results in them having this diagnosis that is now terminal. And I think that's absolutely not an isolated event, right? I'm sure there's dozens and dozens of diagnoses in IDOC that have much worse prognoses than they do on the outside because of how long it takes for people's condition to be recognized in the first place. And I think that's what comes to mind for me as one of the biggest systemic failures, is, how long it takes to get treatment in the first place. Once you exceed all of those other millions of hurdles to even get someone to hear you. Yeah, I'll leave it at that though.
More trauma. You want to hear more trauma? Well, in my situation, on a second heart operation, I had one heart operation, on a second heart operation, they determined not to complete it, saying that they can medically control it. And then I knew something was wrong. And how many years that went on, 5 years, 7 years, until my release. And that was like 10 years later. And the first week upon my release, I went and got medical treatment. And the test results showed, saying to me that every time you exert yourself, the right side of your heart is collapsing. Do you know that? And immediately, you know, what do you want to do? Well, where's the room at? Let's go. You know, and it was just like that. So, you know, you asked the question of biggest systematic failure is that thing that I say follow up. If they would have been taking me to the cardiologist who is a specialist in this, he would have had to test me to find out that I was collapsing my heart every time. But they decided to not take me there. So the people, the medical system in the institution decided to do their own diagnosing and not let me get to where it could have been rectified, that I had to live 10 years like that. So that's the biggest malfunction. And the other part, I think they stopped it now, but was that thing called copay. That that they would make you sick, and I know I'm sick, and I would go and I say, hey man, I have these problems. And they would say, okay, pay $5 and come back in a week, come back in 7 days. And then you would go again and you gotta pay $10 this time to show that you're serious. And then they say, now you can see the nurse practitioner. And then the next time you gotta go 3 times and pay $15, $20, you get $10 state pay, and you gotta pay $15 that you don't have. And then you finally see the nurse to give you like the slogan is, or what you want to call it, the sarcastic thing about all you're gonna do is get a Tylenol anyway, 90% of the time. And I was running around with coronary artery heart failure for 10 years.
I definitely, I was gonna bring it up if you didn't, about if you have a stomach ache, in order to even see a doctor about something, you have to have go through the whole, sick call process 3 times. And just imagine, like, if it's something really wrong the first time, and then I have to wait 7 days and then wait 2 more weeks to come back. Like, yeah, it is.
You know, Gigi, just to mention real fast, the question you had asked about what's the difference of inside there and and being outside. Since I've
Mhm.
been home and I have to go see these medical people, I've been a couple times, and the compassion of them educating me
Yes.
to keep my psychological safety intact and my peace intact. That's the biggest thing. That it's like they were your mother to be, are you okay now? And then, okay, I
Mhm.
understand now, I'm okay. Compared to in the inside, just shut up and beat it and do what we say. And
Yeah.
it's a big, big relief difference of being on this side of the fence.
Something else that's come up for me while y'all have been talking is how communication is also such a issue and something that's so different. And my understanding inside versus outside, like hearing people talk about the struggle of even getting copies of their own medical records to know what their test results said and having to rely on some nurse to relay it to you because you don't have a chance, like Ronnie is saying, to have follow-up appointments at a reasonable time. Loved ones calling the facility to try and get information because they have power of attorney and them being told it doesn't matter. We're not going to give you any information. So unless you can get to the phone, like you're saying, Gigi, unless you feel healthy enough to get to that phone and tell your family what's going on, there's no way for them to know. And then you, as the patient, still, have no idea what's going on sometimes or a lot of the time.
What is medical release, and how does it help people who are in these situations? What are the issues that prevent the system from helping more people?
Yeah. So I can give a brief overview of medical release. The Joe Coleman Medical Release Act was passed, was enacted in 2022 as a result of a lot of efforts of a lot of folks, including folks at the Illinois Prison Project. And so it hasn't even been around 4 years yet. And it makes folks eligible for medical release, which, allows them to be immediately released from IDOC custody and then instead placed on mandatory supervised release, either at home or at transitional housing or in a nursing home or hospital. And the way that folks are eligible for medical release is there's two main ways, one of which being that you are terminally ill, which is defined as you are likely going to pass away within the next 18 months. So a very specific definition. And the other way is if you are medically incapacitated, and that is defined as somebody who needs support with 2 or more activities of daily living, which I never heard that phrase before doing this medical release work, but an activity of daily living in this space is kind of defined as, showering, bathing, personal care like brushing your teeth, washing your face, shaving your hair, clipping your toenails, using the restroom, getting in and out of bed, getting in your wheelchair. So somebody can be defined as medically incapacitated if they fit, 2 or more of those, needing support with 2 or more of those things. So obviously, based on that definition, you can see how narrow the Joe Coleman Act is. It has been an incredible implementation that has allowed us to get, dozens of folks home to their families, either to die with dignity or to be cared for by their families with dignity. But it also has exposed the reality that there's so many people in IDOC custody that just fall short of that, right? People that maybe have to wear a diaper every day and have to deal with that embarrassment and shame every day, but technically don't qualify for medical release, so they can't go home and get cared for by their families. Or people who may be sick and dying, but technically have more than 18 months left to live, and so they still cannot, come out through this mechanism. So it's a very narrow mechanism that has also, brought relief to a lot of people at the same time. And I think that there are a lot of things that prevent this medical release system from helping more people, one of which being education, which we are obviously working on with IPP's education team and a lot of work with attorneys and community inside and outside to help folks understand, who it applies to and who it doesn't. And then I think a big thing is exactly what y'all are naming, Gigi and Ronnie, like this idea of, folks have to go to clinics X amount of times before they can go see a doctor, and they might be terminally ill, but there's no documents reflecting that because they haven't gone through this specific process to be able to see a doctor who's able to confirm that diagnosis for them. Or there's somebody who needs support with using the restroom and needs support with showering, but they can't get it because IDOC is under-resourced. So I think there's a lot of complications, but there's also a lot of families that have been reunited with their loved ones as a result of this Medical Release Act. Yeah, so I think it's a really incredible mechanism, and also something that we obviously still have a lot of work to do to make sure that it reaches a lot of the people that are kind of falling in the gaps right now.
Okay, so last question for both of you. If you could tell lawmakers or the public one thing about what it's like to be sick in prison, what would you want them to understand? And what policy or practice changes would make the biggest difference in improving prison health care?
Well, I would say to the lawmakers, when you come upon that sickness, it could be life and death. It could be that extreme. So number one, I would ask them to pass laws that force the medical system to let the person be treated by the proper personnel, which would be, say, in that case, a cardiologist, whatever, in the proper setting, and not be denied that it be an automatic. That's number one, to do follow-ups. Number two is that when a person's going for major operation, whatever it's for, that they have an armed guard that takes you with guns. So you're not going nowhere. So for them to not let you use a phone or let you communicate to your family that you're going to be there for a week tied to a bed, you're handcuffed to a bed, and you're harmless. You've just been operated. You can't even move, and you can't talk to nobody. So that traumatizes you and the family. So they need to erase that and let that people, they may pass away. They might be their last day after that operation, and let them communicate to their family. And the third part, I would like to see, because I've seen many deaths in the prison of people that needed kidneys or needed liver transplants, and they don't do transplants, and they let you die. And it's a modern day to get to transplant livers and to transplant kidneys and do different transplants. Those are like no-brainers in this era of society where people and the family members wanna give that. And it's just like an automatic, we're not gonna let you do that. So that's like an automatic, we're just gonna let you die. So they shouldn't have that right to do that to a human being. You're supposed to fight for life all the way through to give life, but they let it surrender like that. So those three things bugged me, even though I didn't need a transplant, but I've seen many that did. But in my case, it's the communication going outside and letting them professional people be the professionals.
Yeah, so I'll just say really quickly that if there was one thing that I could tell the public is that there was a lawsuit in 2019 that IDOC reached a settlement on. The lawsuit was called Lippert versus Jeffries. And so as part of that settlement, there is now a Lippert monitor. And the Uptown People's Law Center does a lot of work with this as well. But there are actually reports that are published every year or so that tell folks about what's happening inside of prisons, whether that be, what are the most common diagnoses, what are the most common issues that are happening, what are the staffing rates at different prisons? Because some of these prisons are staffed at like 20% in their healthcare units, which obviously plays a role in all of the things that we've discussed today. And Lippert reports are available publicly. You can just Google Lippert Monitor Report and find that information. And I think especially helpful for folks that have loved ones on the inside. And yes, I just wanted to throw that in there because I think that's a very powerful tool. Obviously, the law is not the only thing that is going to get folks free and get folks the care and dignity they deserve. But I think it's one of many tools. So just wanted to make sure folks are aware of that.
I definitely have to agree with both of you all. It definitely is not anything fun, anything to brag about. Being sick in IDOC is it's scary. Because you somewhere that I hate to say no one really cares. Where you just kind of have to figure it out on your own. And if you don't have a village in there, it does make it a lot harder. Or even people to be able to call and advocate for you. So I guess with that being said, we have a call of action. Our call of action is that you take what you've heard today and talk about it with your colleagues, your community members, and elected officials. Change begins when silence ends. You can also support advocacy groups pushing for oversight and reform like John Howard Association and Restore Justice. Today, we've heard the lived reality of what happens when healthcare fails inside prisons. Delays, neglect, and lives are put at risk. These are not isolated incidents, but systemic issues. A huge thank you to our panelists for sharing their personal experiences, and thank you all for listening with open hearts. Today's Lunch and Learn directly connects to our Joe Coleman Toolkit and Handbook. The handbook is a guide for preparing applications under the Joe Coleman Medical Release Act. It is designed to help incarcerated people, their families, and advocates understand the medical release process in Illinois. It is an educational resource, not legal advice. The handbook explains how to file a medical release application for someone who is terminally ill or medically incapacitated. It provides background information to help complete the Prisoner Review Board's official application form. It also outlines key details about the Joe Coleman Act, its purpose, and how it works. This handbook helps people to navigate a complex process and advocate for early release based on medical conditions. It makes the steps clearer and more accessible for incarcerated individuals and their loved ones. By using it, applicants can better understand their options and strengthen their chances of submitting a complete, effective application. Thank you.
Definitely, if you want to do a call to action for attorneys to come get trained to take some of these medical release cases, feel free to throw that in there because we have a pro bono network that we're trying to grow.